All righty. Hello, everyone. Good morning, good afternoon. Thanks again to you all for joining, and welcome to the third and final installment of this year's webinar series, Supporting Decision Makers Using Opioid Settlement Funds. Today's webinar is titled Multi-Sector Strategies for Collaboration and Decision Making. We're very excited to have you all engage with the content that we have prepared for you all today. My name is Juan Gonzalez. I'm an Associate Program Manager with Prevention Institute. We are a national nonprofit with a mission to build prevention and health equity into policies and practices to ensure that the places where all people live, work, play, and learn can foster health, safety, and well-being. Thank you again for joining us today for this webinar, where you will hopefully learn more about the key role that partnerships play in supporting impactful opioid settlement allocation, and how regional and interagency collaborations can support coordinated decision-making. We are joined today by partners at ChangeLab Solutions and Pima County, Arizona, who you will hear from and learn from in just a bit, and have coordinated this webinar series with Big Cities Health Coalition. A few logistical notes for you all before we dive in. We are recording today's session, and we'll make the slides and recording available afterwards. We have been recording the previous webinars in this series as well, so we will direct you to where those are at the end of this session for reference as well. We encourage you all to use the chat and the Q&A feature throughout the presentation. You will see those at the bottom of your Zoom bar. It's how we'll make sure that we can get to any questions and any comments that you all may have as our presenters speak to you all today. Please feel free to continue to share your name, your pronouns, organization, and where you're joining from in the chat. We always appreciate seeing the reach of our webinar and who we have in the audience today. As a reminder, this project is supported by a cooperative agreement awarded to Big Cities Health Coalition and funded by the CDC. The content that we're presenting today and have presented throughout this series are solely the responsibility of us, the authors, and do not necessarily represent the official views of the CDC or the Department of Health and Human Services. As a very quick briefer on the project that this webinar series is contained in, we have been working now for almost a year, if not longer, to understand the opioid settlement funding landscape across the country, including deep dives on settlement plans, priorities, challenges, and opportunities that we've been seeing in multiple jurisdictions across the country, and of course, conveying this understanding to you all, our public audience. We've been providing technical assistance and capacity building opportunities like this webinar series to local decision makers that are navigating opioid settlement funding processes and allocation in real time. And we are also and have been aiming to build an understanding of strategies that span the continuum of opioid and substance use, including resources that we've developed in-house as Prevention Institute, as Big Cities Health Coalition and partners, but also promoting existing resources and evidence. And again, we will share a resource hub at the end of this presentation where you can access all of the content that we've been developing for this project so far. We are going to go ahead and get started and turn it over to our partners at ChangeLab Solutions, who are going to kickstart our conversation on partnerships in opioid settlement fund processes and decision-making. Joining us today from ChangeLab Solutions is Jessica Breslin. As a senior attorney at ChangeLab Solutions, Jessica works on law and policy related to economic justice, health equity, tobacco, and healthy communities. Jessica comes to ChangeLab Solutions from Bay Area Legal Aid, where she provided civil legal services coordination, advice, and direct representation at the Alameda County Collaborative Court, and built a project that provides special education and SSI advocacy to disabled, delinquency-involved foster youth. Jessica also represented adults with significant mental health impairments on their release from jail in a variety of public benefits matters. Jessica earned her law degree from Georgetown University and her bachelor's degree in social work and politics from NYU. Jessica is joined by Christine Camilleri as a senior planner at ChangeLab Solutions. Christine engages with programs and projects that focus on the intersections between policy, the built environment, and health equity. Christine has been part of the overdose prevention team at ChangeLab Solutions and conducted research and outreach to inform creation of policy selection and implementation guides in partnership with the Network for Public Health Laws, Harm Reduction Legal Project, and the CDC. Now, prior to joining ChangeLab, Christine worked at a variety of community development and affordable housing nonprofits and the New York City Department of City Planning. In addition to her planning and policy endeavors, Christine's volunteer life includes supporting harm reduction efforts in North Philadelphia, where she lives. Christine holds a master's degree in city and regional planning from Pratt Institute and a bachelor's degree in human development from Cornell. We're super excited to have you both join us today. And to our audience, please join me in welcoming Jessica and Christine. Over to you all.
Great. Hello, everyone, and thank you so much for that introduction, Juan. I'm going to start by leading us into the first section of this session today by sharing a bit of level setting and getting into defining the terms policy and speaking in greater detail about what we mean when we talk about the policy process. And as I do that, I'm going to share some examples to ground us in the context of this work and topic specifically. And then once I do that, I will hand it over to my colleague, Jessica, to lead us into talking more specifically about the importance of partnerships. And then we will turn it back to Prevention Institute to lead us into the panel discussion. And so I think, as was mentioned earlier, we'll have time for questions later, but in the meantime, you can feel free to send questions through the Q&A function, and we will do our best to monitor that as we're moving through this content. And so, as I think based on the introductions in the chat, I think a lot of our participants here today may know that payments from opioid settlements are expected to total more than $50 billion over an 18-year period spanning from 2022 to 2040. And these are funds that are currently being dispersed to state, local, and tribal governments across the United States. These are also funds that provide a critical opportunity for local policymakers to invest in public health interventions that can potentially save lives, as well as mitigate growing disparities in drug-related harm, including overdose. And so local government agencies are very critical partners in this effort, as they can provide subject matter expertise and decision-making support to people and entities involved in coordinating and allocating this settlement funding. And to make sure that opioid settlement funds are used effectively, it's also essential to involve local partners, such as harm reduction groups, health clinics, and people with lived and living experience in every single step of the process to ensure that these resources are meeting real needs and getting to the people who need them the most. And these local partners know the real needs on the ground and can guide investments towards life-saving strategies such as naloxone distribution, providing overdose prevention education, and getting people access to treatment services that are accessible. And in addition to this, something we'll talk about a bit today is the importance of cross-sector partnerships with the people and groups that may ultimately use these funds to implement programs to ensure that these resources have the furthest reach and the most equitable impacts. And so these are things we're going to dig in a bit more. But moving to the next slide, we want to begin at the beginning and define what we mean when we talk about policy. And so part of this definition is that policies are written statements by public agencies or organizations of their positions, decisions, or courses of actions. Policies include laws, regulations, procedures, administrative actions, incentives, or voluntary practices of governments and other institutions. And so I just said a lot of words, but on the next slide, we have some examples. This graphic shows some common examples of what you might think of when someone says policy. Just an example of one of these that's actually fairly specific, zoning policies that make it possible to operate syringe service programs or overdose prevention centers, for instance, is one sort of example. Something that you probably see on the top of this slide is when we talk about this bucket of policies, something we use to refer to this particular bucket is we talk about big P policies. Big P policies have a key characteristic, which is that these are policies that are passed, approved, or ordered by a government body. And we also have kind of another subset of policies we refer to as little p policies, which I'll talk about in a minute. But to help drive this point home, I'm going to share an example that connects to opioid settlement funding, which highlights a few elements of policy making that can advance equity. So moving to the next slide, this is an example in Colorado where on May 14th, 2025, the Colorado Opioid Abatement Council voted to award $5 million in funding to 12 organizations and local organizations throughout the state that are engaged in work to address needs related to opioid use. And this is an investment that is intended to fund capital improvements and operational support in 13 of Colorado's 19 opioid regions. Notably, a percentage of the settlement funds were explicitly set aside for communities that were or have been disproportionately harmed by opioid use, such as rural areas, tribal communities, and lower income urban neighborhoods. There's kind of two specific elements of this policy that I want to uplift as they center equity. First, I want to touch on how this policy engaged inclusive decision making, which is the Colorado Opioid Abatement Council requires local planning bodies to include representatives, including people with lived experience, people who work in harm reduction, and tribal leaders to play an active role in deciding how the funds are used. In addition, the policy went further upstream to attempt to address the root causes of health inequities. So for instance, rather than focusing solely on treatment or law enforcement, the policy allocated funds for evidence-based prevention, such as youth education in schools and also harm reduction. And so with that example in mind, I'm going to move to the next slide and go back to our definition of policy. And so when most people hear the word policy, they think of laws and legislation, even budget allocations, like we were just talking about. People think of ordinances passed by city councils and legislatures at the state, local, and federal levels, and that's absolutely a very important piece of this. It's also important to consider little p policies as well. And so this is a bucket of policies developed outside of government branches. This includes private and non-governmental policies like workplace policies, nonprofit guidelines, and other sorts of policies that guide program development and implementation. And there's a few reasons little p policies are really important. They provide an opportunity to memorialize work internally at institutions and across agencies without requiring the explicit approval from government entities. And at the same time, it it is important to note that any little p policy developed or implemented has to still comply with applicable laws. So, for example, while a workplace can set its own salary policy, it has to still comply with applicable minimum wage laws. So we want to make sure to mention that. But on the next slide, there we have some examples of what falls into this bucket. So, for instance, work or project contracts, such as contracting with harm reduction organizations and community-based organizations, personnel policies in the workplace, like policies that might make it easier for people who use drugs or who have had interactions with the criminal legal system, are both examples of little p policies. And so depending on the nature of your work or scope of work, these little p policies can actually be just as influential as big P policies because they can serve as testing grounds for those big P policy changes down the line. And also, these changes are typically very tangible. And so there's a few reasons we want to be talking about them today. And so that said, I'm going to talk through another example. This one is going to be a little p policy that ties into opioid settlement funding. And so this one is in Cleveland, Ohio, and where, as part of Ohio's conditions for receiving opioid settlement funds, major healthcare institutions like the Cleveland Clinic were required to adopt new internal policies. And so in 2023, the Cleveland Clinic implemented a system-wide opioid stewardship policy, which was in alignment with conditions defined by Ohio's Opioid Abatement Council. And this was an effort supported, at least in part, by settlement dollars. And there were a few key elements of the policy. These included revised opioid prescribing guidelines, as well as mandatory provider training, with all clinicians being required to complete an annual opioid stewardship training. This also involved guidance related to naloxone co-prescribing. It also involved partnerships with harm reduction organizations to provide overdose prevention education, as well as shifts to risk screening of patients for opioid use disorder and referral practices. And so the key thing here is this is a little p policy because it was adopted at the organizational level by a major healthcare institution. And on the next slide, I'm going to share another way to visualize this, which is the program to policy spectrum. And what this really shows is we can visualize this work as a spectrum that is critical for improving health outcomes and advancing health equity with varying levels of impact. So on the left side, you have programs that are shorter term interventions that can create temporary improvements to address challenges. And the policies that fall further to the right include things like covenants that are articulated in legislation and regulation. And I think, important thing that I want to emphasize here is that programs and work that falls further to the left side of the spectrum have the capacity to lead to more systemic policy changes that are further to the right. And so programs or little p policies are typically more discrete and limited in scope, but they're still very important because proving their efficacy can help lead to broader, larger scale changes that may be codified in statute, ordinances, or formal agency policies and practices down the line. And it's also important to recognize that ultimately programs cannot eliminate the systemic injustices that any group faces. However, they can help people to manage the effects of these injustices, though they cannot overcome or cure them. Policies, conversely, can actually, further to the right, may have the potential to shift the way communities react and relate to one another, empowering people to improve their own well-being in a systematic way. And so considering all of this, the real takeaway on this slide is that it's really important to implement interventions that span this spectrum from program to policy to achieve the greatest possible public health benefits. And on the next slide, I want to share a few notes on the policy process itself. So some of you may be familiar with this image because it is the Center for Disease Control and Prevention's policy process wheel. It includes a visual representation of the phases of the policy process, including identifying the problem, considering and analyzing possible approaches, developing strategy, and implementing and evaluating the impacts of policy change. And we like this model for a few reasons. First, it's circular, so that helps emphasize the iterative nature of the policy process. It's really rarely, if ever, a straight line or, a really straightforward circle, even as this suggests. Um, and is an ongoing process that may be a little bit more of a spiral than a circle sometimes. Also, we like that it keeps engagement with partners in the center, which helps us to remember the importance of engaging with community members and partner organizations throughout all steps in this process. So not just at the end when a law is to be changed or introduced, really from the beginning and throughout. And in the context of opioid master settlement funding, engaging people with lived experience of drug use and the people who work directly with them early, often, and meaningfully is absolutely critical for determining needs and possible solutions. The beauty of this is that when it comes to implementation, when a law or program is to be rolled out, these relationships, if they are already formed, can make it so partners can play a role in evaluation, which is something that can happen on an ongoing basis to ensure that policies have intended impacts. And also partners can help share information about new policies, policy needs that may arise. And so we'll talk more about that in the latter portion of the presentation. But on the next slide, another critical part of the policy process is it's helpful to have a clear vision of the role or roles you might fulfill in a process like this. And so I personally feel very strongly that if you're here in this session or listening to the recording, you have a role to play. And we have indicated some potential examples of potential roles on the right, such as issue expert, advocate, or educator. It's possible based on your job function or the organization or entity that you work with that you may face constraints about what you are allowed to do when it comes to things like direct or grassroots lobbying, but there are many different and equally important roles to play. And an effective policy effort involves aligning all parties on where they fit into into this process and how they can be most helpful. And on the next slide, I want to share one more example that touches on some of the elements of the policy process that I just spoke about. This one is in Cabarrus County, North Carolina, where a strategic planning process was engaged in around their opioid settlement fund allocation, which had a few goals. First, to identify strategies to address opioid use through prevention, treatment, and recovery. It also aimed to inform the use of local opioid settlement funds and engage in meaningful partner engagement. And so the strategic planning process that they launched was rooted in both data and evidence and conversations with community partners to build upon former and current efforts related to drug use, addiction, and drug-related harm. And this process through this process, they worked to identify individuals and organizations that could speak to the realities, needs, and values of those most impacted by opioid use. And notably, the planning process involved a multi-pronged approach to engagement that included a combination of community surveys as well as facilitated focus groups, including 4 separate focus groups that engaged people with lived experience recruited from local clinics, as well as individuals currently detained in the county jail for opioid-related offenses. And so the strategies detailed in the strategic plan, which is available online, directly reflect this input as well as other input that they collected and gathered, and just but one example of what that partner engagement could look like in a process like this. And so with that, I'm actually on the next slide going to move us into a poll. Now that we've talked a bit about policy and the policy process, and I think we're really curious to hear who we have in this space today, and specifically hear more about what part or parts of the policy process that you feel you have plugged into the most. And so I'll give folks a minute to select options, and I believe you have the ability to select more than one as it is multiple choice. So just want to name that, and I'll be really interested to see what comes in, and I'll kind of report back to the group in a minute. I'll stop talking so folks have a chance to think about this and ponder it a bit. And I see some folks may have placed their answer in the chat. That's also great. So I think, okay, fabulous. So I'm seeing the results now. And so I think we have a lot of folks who selected problem identification, strategy and policy development, and partner engagement. So that's really fascinating and something I think will be really interesting as we move into the next portions of this session. But really, I mean, overall, it seems like we have some pretty good representation across a lot of different phases of the policy process, which is fabulous. And so that's really, really interesting to see. So thank you so much for sharing that feedback and giving us a little bit of a glimpse into who we are having the privilege to engage with today. With that, I'm actually going to turn it over to my colleague Jessica to help us dig deeper into navigating the policy process and ensuring the impactful and sustainable allocation of opioid settlement funds through partnerships. So Jessica, I'm handing the mic over to you.
Thanks, Christine. So there are, as we've been talking about this whole series, there are several strategies available to help local leaders ensure that funds for opioid settlements are invested in ways that best respond to your specific community's needs. And so as localities plan and implement settlement funded activities, one of those strategies that we wanted to highlight today is to build partnerships across the institutions that touch the lives of people who use drugs. And so on the next slide, we'll talk a little bit about why, although with how many of you answered partner engagement, I'm sure you guys have some sort of base idea, but collaborative partnerships are a critical building block of impactful and sustainable interventions. And so for planning and implementing opioid settlement funding, this means building partnerships with people who use drugs, others with lived and living experience, organizations and institutions that can provide firsthand insight about those needs of the people at greatest risk of overdose, and then help deliver the needed interventions. Successful partnerships have alignment on their goals and the way to get there. They also work to share decision-making power and are clear about the role each entity will play. And you may get tired of hearing us say this today, but partners should include impacted community members themselves, the community-based organizations that serve them, other government agencies, advocacy groups, academics, elected officials, and many others. And on the next slide, I'm going to talk a little bit more about that. So municipalities can use settlement funds to facilitate collaboration among people and entities whose insights or support can help address the overdose crisis. This should foremost include people who use drugs and others with lived and living experience, including people in recovery, those at high risk of developing substance misuse disorders, and the family members and friends of people who have experienced overdose. So on this slide, you can see that we've sort of divided it into 3 different categories. The first is health. So that would be things like people like healthcare providers, different health systems, health departments, behavioral health, treatment providers, and those working in the harm reduction space. You also want to think about and consider cross-sector partners. So people like housing providers and orgs, school and education agencies, legal aid and other criminal justice organizations, research and academics, human services, community-based organizations, and then policy and advocacy organizations. And then lastly, just to underline again, you really want to make sure you're incorporating people with lived or living experience. So people in recovery, individuals at high risk for developing substance use disorders, people who use drugs, and the friends, families, and caregivers for people who use and or used drugs. And one thing to note about these types of partners is many of them are bridge builders between local government and people with lived and living experience. So they have existing networks and relationships that can help support with buy-in and trust when you're working with these communities. And if you can think of anyone that I might be missing, because I'm sure there's so many different options for partners, we probably missed some, feel free to drop those in the chat so we can share with everyone. And then on the next slide, we have another poll for you. So again, you should be able to choose more than one answer, but if you want to go ahead and answer the poll for which partners you engage with or have you engaged with in the past. Then once everyone has had a chance to answer, we can check out what the results were and then talk a little bit more about how partnerships can help. So it seems like a lot of you have partnered with community-based organizations. That's 90%, which is great and awesome. And then it seems like only one of you said none of the above. So that's really encouraging to see too. And it's great to think about all these agencies engaging with them. So on the next slide, we're going to talk a little bit more about how partnerships can strengthen the process. So regional and interagency partnerships can be formed and leveraged across the continuum of phases of managing opioid settlement dollars. So that means during planning, implementation, and evaluation or iteration. So when we're first thinking about planning, Partnerships during the planning process can build together traditionally siloed sectors and harder to reach community voices. So they could serve as trusted conveners to make inclusive partnerships that foster shared ownership of strategies and ensure that multiple perspectives inform the planning efforts. They can also help ensure authentic community engagement. So interagency partnerships can bring people with lived and living experience, CBOs and service providers into the room early and in meaningful roles, such as steering committees or advisory groups. And this early engagement can foster shared understanding and collective ownership of strategies. They can also help map assets and gaps across systems. So regional partnerships support shared understanding of services and needs, helping to avoid duplication and surface community-specific gaps. So that might be access to housing or things like that. And joint community assessments can help identify priorities and inform equitable allocation of the funds. Um, Also, these partnerships can help align regional priorities. So coordinating with neighboring regions can function to align your objectives, share best practices, and make sure you're avoiding duplication of efforts. This regional alignment also facilitates resource pooling, unified messaging, and the development of comprehensive strategies that address broader community needs. Finally, partnerships across counties and cities can ensure that overlapping systems like emergency systems, hospitals, criminal justice systems have consistent goals and strategies. And then on the next slide, we're going to talk about a specific example. So one example of how strategic partnerships can strengthen planning can be seen in Indiana. When planning the use of, opioid settlement funds, the city of Frankfort and Clinton County in Indiana created an intergovernmental task force in order to align how the two jurisdictions would use the funding. The task force is comprised of city and county officials, first responders, health department representatives, and practitioners. So for example, after working together to assess county and city needs, the task force decided to use the settlement funds solely on opioid abatement, and then used a community needs assessment to further decide to use the funds on recovery housing. Next slide. Multi-sector agencies can also leverage partnerships to inform activities during implementation. So this might mean leveraging existing networks and infrastructure, so utilizing established regional coalitions and interagency collaborations to expedite program rollout and enhance efficiency. Shared infrastructure can improve service delivery, reduce costs, and increase the reach of interventions. This can also allow you to pool your resources for greater impact. So regional collaborations can braid settlement dollars with other funds like Mental Health Service Act funds, and Medicaid, supporting integrated programs that no one agency could fund alone. Collaborative funding enables comprehensive services such as integrated treatment and housing programs that address complex needs more holistically. They can also help you standardize best practices. Interagency coordination can enable joint training, shared protocols, such as for overdose response or care navigation, and common service models. Standardization also enhances coordination, improves the quality of the care, and ensures that all partners are aligned in their approach. Lastly, these partnerships can empower frontline leadership. So community-based organizations or people with lived and living experience led organizations often already have trusting relationships with communities most affected by the crisis. Partnerships with local governments can elevate their leadership and ensure funding is accessible to them. For example, as acting as fiscal intermediaries or providing grant writing support. And on the next slide, we're going to look at another specific example. So in Washington, D.C., they created an advisory commission that has a variety of required members, including government officials from different relevant agencies and offices. It also includes members that that are individuals with medical expertise, people with experience providing direct services, as well as people with specific experience in providing recovery services. The Commission also requires participation of members with lived experience, including those who have substance disorders and family members of those who have substance disorders. And then one of the things that came out of this commission and working together is when I was talking before about braided funding streams, they were able to decide to combine the use of the settlement funds, SAMHSA grants, Medicaid, and other CDC grants in order to create a more comprehensive approach to opioid abatement. And next slide. So partnerships can also be used to strengthen evaluation and iteration. So one way they could do this is by developing shared evaluation metrics. They might agree on common indicators to measure program effectiveness across agencies. They can also create shared metrics that facilitate comparative analysis, collective learning, and the identification of best practices. Another way that partnerships can help with strengthening evaluation is establishing data sharing agreements with MOUs and strong trust. Regional partners can share real-time data such as EMS calls, naloxone use, or treatment entry to spot emerging trends and coordinated rapid responses. Data sharing can enhance transparency, inform decision-making, and enable timely adjustments to programs. Another way that these partnerships can help is regularly reviewing, reflecting, and addressing strategies. So interagency teams can regularly review what's working and reallocate funds accordingly, ensuring investments remain responsive to the evolving needs. These continuous feedback loops support adaptive management, responsiveness to emerging needs, and the refinement of interventions. Lastly, they can help disseminate findings and best practices. Evaluation, as I'm sure you know, isn't just about reporting. Regional partnerships can foster peer learning spaces to elevate promising practices and address implementation challenges together. This could involve sharing evaluation results and lessons learned, both with key partners and importantly, back with the people with lived experience and the groups working with them. And then on the next slide, we'll talk about a specific example again. So in Minnesota, they produce an annual evaluation of opioid settlement funded projects for the state legislature. This evaluation summarizes settlement funded projects and assesses Minnesota's progress towards its opioid abatement goals. They also produce a public dashboard in order to track the progress. The council that works on these evaluation and maintains a dashboard is made up of a wide variety of cross-sector partners, including local health departments, community actors, and substance misuse experts, and many more. And with that, I believe we're going to pass it over to Pima County for a more specific example about how they've worked on these issues.
Thank you so much, Jessica and Christine. As a reminder to our audience, if you have any questions for them or for our upcoming presenters from Pima County, please feel free to share those in the Q&A feature. We'll keep an eye out for those and bring them up at the end of the conversation. We are now excited to introduce our partners from Pima County, Arizona, who will be sharing more about the work and priority setting processes of their regional opioid settlement advisory committee. We're joined today by Dr. Christina C. Bell Andrews, who is Hiachu Da'atum and a member of the Thana A'atum Nation. On her father's side, she is Pasquayaki through the lineage of Castellum. Her professional experience has been in government, law, health, and human services, and education at the tribal, state, federal, and international levels. She is an assistant professor and executive director of the Wasaja Carlos Montezuma Center for Native American Health under the College of Medicine at the University of Arizona. The Wasaja Center is an Indigenous-led framework to empower and heal Indigenous families using a culturally appropriate holistic approach where Indigenous knowledge and data will be protected through law and policy. It envisions engagement and understanding between European-centric and Indigenous systems to advance health and social justice outcomes for Indigenous peoples. We're also joined by Brian Eller, who is a public health leader with deep experience in behavioral health, systems change, and community-rooted innovation. He serves on several nonprofit boards, including those focused on youth development, behavioral health, and gender-based violence prevention, providing leadership in strategic planning, policy development, and organizational accountability. Brian bridges policy and practice, advancing equity-driven programs that support substance use recovery, mental health, and survivor-centered services. He is known for centering lived experience, fostering cross-sector partnerships, and building trust within communities. Passionate about blending art, culture, and health, Brian helps shape environments where healing, housing, and dignity are possible for all. The floor is yours, Brian and Dr. Bill Andrews. Thanks for joining us.
Thank you, Juan. I appreciate that. I definitely appreciate a lot of the context that was brought about in the previous presentation as well. There's a lot of stuff that I think bridges really well with what we're going to share today, with what we've been doing. Again, my name is Brian Eller. I use he, him pronouns. I'm the division manager for Community Mental Health and Addiction Division at Pima County Health Department. I'm going to be discussing the Pima County Regional Opioid Settlement Advisory Committee with my colleague, Dr. Christina Andrews, as one mentioned, from the Wasajua Center, and who is also a member of the Regional Opioid Settlement Advisory Committee, which we'll be referring to as ROSAC throughout the duration of this presentation. I do want to start off with a quick land acknowledgement, and I apologize for the format of the presentation today. I am unable to use PowerPoint or any other Microsoft Office products for whatever reason. It's some weird firewall. So you'll get to see the deck on the left as I'm navigating the slides, and this will be available to all of you. I do want to start off with a quick land acknowledgement for us in Pima County. We honor our tribal nations, which should be capitalized in this slide. This is something I could not edit for some reason, who have served as the caretakers of the land in which we occupy for time immemorial, respectfully acknowledge the ancestral homelands of the Tohono O'odham Nation and the multi-millennial presence of the Pascua Yaqui tribe, which should also be capitalized there within Pima County. Consistent within Pima County's commitment to diversity and inclusion, we strive towards building equal partner relationships with Arizona's tribal nations. And this is one of the ways that I actually wanted to, and one of the important reasons why I wanted Dr. Andrews to be on this presentation with us, is to share out how we try to move towards action within these acknowledgement statements, so that it's not just saying things, but actually trying to move towards substantial action and involvement and decision-making with our tribal relations. To bring some context, I'm going to share briefly out some efforts that we've used to address opioid use in Pima County. This is just a quick overview of some of our community partners that we work with. Kodak, Hope, and TIC, Tucson Indian Center, are all integrated health partners subcontracted to address stigma and harm reduction with law enforcement and fire departments, exchanging a lot of data to find out the context of where non-fatal overdoses are occurring. El Rio is one of our major FQHCs, which has multiple locations and also assists with our Narcan distribution. U of A Center for Chronic Pain and Addiction helps with evaluation and obtaining other OD2A outcomes for us, since we're an OD2A local site. The Arts Foundation for Tucson and Southern Arizona, we have some really creative, unique projects that have come in as a result of that collaboration, which we'd love to share out at a future session if that's possible. And then a highlight on our Tohono O'odham HHS partnership, and many, many more. Overall, 2025 progress to date. We just recently held a 2025 annual behavioral health conference. It was the first one that we had. We had a month to plan this and carry it out, and we had 257 attendees. Really important, because there was the in the previous presentation you heard a lot about policy. Well, this particular conference is going to frame out a lot of how we'll address some of that policy with ROSAC. So I'll talk a little bit more about that later. We had a youth stigma campaign to address stigma within youth populations. Saludarte is a program that we use, that we leverage with our Tucson Foundation for Arts to actually display work by people who use drugs, artwork in settings to address stigma. We just started the Suboxone Quick Start program, and in just a couple of months, we've already had 35 completed referrals. And then a lot of interactions with people who use in our community through Hope, Pima County Health Department, and Tucson Indian Center. This year so far, we've deployed over 9,000 Narcan units, over 5,000 fentanyl test strips, over 5,000 xylazine test strips, and held a whole load of education. We use a lot of GIS mapping to figure out where we focus on the deployment of these resources based on non-fatal and fatal overdose, which heavily corresponds with a lot of social vulnerability indices throughout census tracts in our community. Just some quick data dives on how we're doing from overdose deaths in total here. As of May 2025, we were up to 2,286 cases across the board from 2017 on. Our fentanyl trend, our fatality trends overall right now, looking at a month-by-month comparison. This is important because this year we're actually seeing an increase again, which is a concern for us. So you can see January, there was a tick up from last year, not quite as bad as January from 2023. February, definitely an increase across the board of overdose-related deaths, and March, same thing here. The age-adjusted categories for 2025, we're seeing primarily increases in 30 to 69-year-old populations. And when we break down the demographics and adjust this by racial ethnic demographics and look at it per rate, there's definitely a significantly higher number of population of American Indian Alaskan Natives. Quick takeaways that we want to highlight from this, from January to March of 2025, total fatal overdoses from, again, January to March were 134 deaths, which was up 16% from our last quarter. The fentanyl-related deaths have increased by 16%. Our methamphetamine-related deaths have been increasing by 24%. You can see the comparisons to previous years here in the next part of the slide. And really why we're wanting to highlight this is, we kind of thought in 2024 that we were really addressing the overdose crisis. And what we're seeing is that there needs to be some changes in how we're doing the work, and that we're not fully addressing the way that we thought we were. If the current trajectory for us continues, the annual overdose deaths may exceed 500 in 2025, which would be a new record for our county. The context for that is important in moving into the background of opioid settlement fund distribution, because the kind of projects that we can allocate funding to, I think, are potentially a little bit more diverse and can fall upon a broader spectrum of prevention and addressing overdose-related fatalities as a whole. So we started off with One Arizona Opioid Settlement Funds, where those funds in Arizona were divided among jurisdictions according to a One Arizona agreement from the federal distribution. Pima County is the fiscal administrator of all those allocated funds. One of the unique things about us, and I heard this about another district in the previous presentation, or another jurisdiction, is that Pima County, the city of Tucson, the city of South Tucson, and the town of Marana, which are 4 of the 6 jurisdictions in Pima County, have all chosen to pool their funding. And that is fairly unique in the national landscape. I believe I've heard of 5 other counties that have done similar work. The initial iteration of this, of the distribution of that funding, was allocated through a substance misuse advisory committee, which convened from 2022 through 2024. It was primarily made up of members from the Board of Health. They reviewed best data and best practices, identified 20 community advisors, conducted 5 90-minute focus groups with 17 community organizations, surveyed over 1,000 community members, and then recommended and implemented 4 specific actions: initial staffing, Narcan funding, 2 RFPs, one for mobile MOUD services, medication for opioid use disorder, and one for services for pregnant and parenting women. Those contracts were awarded and are concluding this month. RFPs are requests for proposals, which are how government entities send out funding from this particular funding source. The previous funding expenditures, just in more detail here, giving you a sense of what those look like. The staffing included those 2 positions and what the Narcan purchase and distribution looked like, and then the packages that were awarded to Kodak through that competitive process. I think it's important to highlight when the Misuse Advisory Council decided how funding should be allocated for our community, they really looked at the distribution among primary, secondary, and tertiary prevention, right, which is The base of that funding, 42%, should be allocated towards prevention, which was the reduced the need to self-medicate, controlling access to addictive substances, and promoting protective factors across the board. 35% of the funding used to screen, diagnose, treat substance use disorders, and reduce stigma, and then 23% to prevent fatal outcomes. So after that committee or that council kind of absolved, we moved into the iteration of the Regional Opioid Summit Advisory Committee, or ROSAC again. In 2024, this group, we shifted from the Board of Health over to this committee, which is overseen by the Board of Supervisors at the county level. They were responsible for the selection and recommendation of funding for One Arizona approved expenditures. We've held 15 meetings so far. It'll be 16 next week, from July 24th to June 25. And ROSAC really has done three primary things. And these are kind of in reverse here: identifying areas for projects to be funding, performing in-depth studies of approved funding categories by ROSAC, and then creating the functional structure, appointing a chair and a co-chair as that committee continues to move forward. The attendants and those members include Dr. Andrews Bell, who will be presenting here momentarily, Dr. Lisa Soltani, who's one of the medical directors for El Rio, Lee Hopkins, who works for the City of Tucson in the Housing Management Program and the Community Health and Wellness, or CASHU for short, Jesse Lasoya, who is a City of Tucson rep, but owns a behavioral health care center out on the east side and does a lot of work around substance use prevention. Chief Roberto Jimenez from the town of Marana, who is the deputy chief for the town of Marana Police Department, and Brian Flagg, representative from City of South Tucson, who sits on the city council and for 40 years has been running food security nonprofit through Catholic Relief Services, who intimately knows poverty in that community and has a lot of interaction on the daily with individuals, people who use drugs. The committee is staffed by the Pima County Health Department. We do a lot of the footwork. The committee says, hey, we want to learn more about youth prevention and how that intersects with this. We want to know about more about mobile MOUD. And then we go back, we do the research, we present it to the committee, and then they produce the recommendations for the Board of Supervisors to approve. And I want to make sure we tag into that a lot of these efforts are informed by people with lived experiences. I'll talk a little bit later about the Community Advisory Board and how those recommendations get presented to the committee. But I'm going to pass it off to Dr. Andrews Bell to just touch base on a couple of slides here at this point. I'll mute myself. And then Dr. Andrews, just please tell me when to advance slides.
I think you guys already have, Mr. Gonzalez already introduced me. So I wanted to say thank you for having me here. I think this is an amazing group, by the way. I love that you guys are looking into those populations that are underserved and underrepresented. But so I just wanted to point that out. The only thing I wanted to add here basically is that I am also a tribal leader. I sit on as an alternate on council for my tribe, the Tohono Nation. And I was a former chairwoman as well for, and my tribe actually 75 miles borders Mexico. I think that's important. So we deal with 3 laws, the United States, we deal with the international law, and of course the tribal law. And I was looking at all the people here, and I see that, you know, you guys are all over the United States. So not every state deals with the tribe, but, you know, I see some of the people here who do deal with tribes, and what we found. Oh, I'm going to go ahead and go to the next one. Okay, so I was invited in 2024 to help. It was more like to give that lived experience of tribes. And we kind of, and I'm just saying this because if you don't have somebody on your area, and again, it could be from whatever community, but I'm talking only about the tribal people, is because of the fact that you know, I was brought in to talk on behalf of the tribes, but then when we got involved in this, you know, our roles became clear. And it's okay, I guess, to say, hey man, I don't know what to do at the beginning of forming these kinds of committees within the deep rooted community, but it will evolve, I promise. So anyway, so what I'm overseeing, or we're looking at now, is the urban tribes, but with my background in tribal communities, I always bring that to an issue, and I'll talk about that in a moment. But I really like the fact that Pima County said, hey, we're going to include the tribes here. And I appreciate that. And I'll talk a little bit more why, because we're not a minority race. We are a political entity with the federal government. So I just wanted to point that out. I'll point it out later on. But I do appreciate the openness of Pima County and bringing that voice to the table. Ensure Native, what I do in my role is ensure Native American representation in Pima County in terms of landmass, population, and jurisdiction is heard. Just giving you an idea, in terms of landmass, about 42% of Pima County's landmass is tribal, is on reservations. That's big. And for example, my tribe, the Tohono Nation, it borders Mexico 75 miles, but it's 2.8 million acres alone. Part of it is in Tucson, some of it's in Gila Bend, but the larger landmass is 2.8 million, the size of the state of Connecticut. And I'll talk to you why that's important. The population also in Pima County is like 3.3% of Pima County's population is Native Americans and self-identified, okay, Native Americans, I should say, because there's a situation with that as well. So Pima County really deals with three jurisdiction. Well, I would just say really, yeah, because they deal with their own jurisdiction, they deal with the state's jurisdiction, but they also deal with tribe jurisdiction, which I'm again wanting to emphasize that. So if you guys do, like I saw North Carolina, you guys have tribal communities in there. Don't forget us, because we're usually a part of your group here. And that was something we kind of discovered. Somebody was in our group saying, oh, well, the tribes have their own opioid settlement. Well, they do, but we usually get services off the reservation. So we now become a part of your population because we go back and forth. So please keep that in mind. Work with the team. What we did is we created our own. So even though I'm one person on this committee, I have a group that I refer to who are experts in. I am not an expert in the opioid. I'm not an expert in that. But I got people who were tribal people who are experts in it at the table, and they became their voices became what I would bring to the table. So we had Dr. Marcos Moreno, who is an MD, but he's at Harvard, but he's from the Pascoyaqui tribe, and he's born and raised on it. We have Dr. Chris Sharp, who is from Arizona State University, who deals with social work, but deals with the opioids as well, settlements, and the tribes. We also have Dylan Bayesa, who is the Tucson Indian Center. He deals a lot with the urban Indians, but he's a part of this as well. And Matt Ignacio, I don't know what tribe he's from, but I do know it's not one of the Arizona tribes. I know it's off. But Matt Ignacio, I should also say Chris Sharp is from the CRIT, which is the, CRIT, I can't believe I forgot that one. But CRIT, they're more up northwest, Colorado River Indian tribes, that's what it is. And then Matt Ignacio, he's from the Tohono Nation, and he is a doctor in also dealing with, it was dealing with harm reduction, but he deals with social work as well. Okay, go ahead. So now we have a team at the table. And so when it comes to issues that are impacting our Indigenous relatives, first of all, I also wanted to stress here that when I stress that we go on and off the nation, the other thing is that we are a political entity. And people say, well, what does that mean? Well, we don't fall under DEI 1, but what it does is that when the United States was being formed, basically, when the colonizers came, we had genocide, we had the takeover, we got that. When that happened, there were these treaties that were made, or these promises that were made to these tribes. And that was two things. One, we're gonna, for the entire life of this existence of this United States, for the taking of your land, what we're gonna do is we're gonna provide you medical assistance and education. So that's important to note. We're also in the United States, I think it's Article 8, we're underneath the United States Constitution as being where the United States Congress deals directly with us. So we see a lot of the federal government more than the state in here at Pima County. But the point is that We are not minorities. We are a political entity. So we deal with government, we deal with we deal with government to government relationships. So it's not like, oh, well, their tribe, we're just going to go over there, provide narcotics. No, you have to deal with the chairperson, the person who's the head person, and understanding those nuances of dealing with the tribe. So really, you guys have, because you do deal with tribe, even though they're, for example, let me give you an example. A mother who is on opioids, or she's having a baby, we don't have a place on the reservation where she would have her baby. She'd automatically be sent to hospitals off the reservation. So now you're dealing with a Native American who, you know, is in your hospitals and receiving services. So even though they're tribal people, they're still a part of your jurisdiction now, because now they're off. So just to keep that in mind, that there's still that government to government relationship. And the whole purpose of this was because of the treaties, and because the tribes were given this innate ability to continue their sovereignty of overseeing their members. So even though that member might be off, that's still their member. And so the tribe still will have what they believe anyways, jurisdiction over that person, because they're a member of their tribe. So these nuances are very important not to forget. If you are from a state that deals with tribes, it's not like, oh, well, they got their own and we don't have to. No, you do. Once they hit your jurisdiction, they now become a part of you. And that's only those on a reservation. We have a lot of urban Indians. Anyways, I just wanted to point that out to you, just to understand that. That's all. And I say that, and we created some kind of clauses, that things to think about when you guys are dealing with tribes. And I believe that Mr. Gonzalez is going to email those to you guys later. But one thing, for example, we see a lot of mothers, as he had mentioned, you know, that's a lot. The mothers going into the hospitals, having babies. But once you guys hit any child, any baby or infant, and you deal with them, whether it's in the hospital, off, what have you, but they're Native Americans, now you're dealing with the Indian Child Welfare Act. Now you're dealing with federal law. And it's not just, we're going to treat them just like the state. Then we're dealing with violation of a federal law. So with that, these nuances are very important to know. And it's also important to know, and I place that in the consideration, that because there's federal law also when dealing with tribes with the self-determination, they have to be included somehow. They can't be like, oh, we're not going to have anybody dealing with you should have somebody who deals with tribes, you know, somebody who understands that. And I do place that in that consideration pamphlet that I gave to you all. But I'm gonna have to move forward. I just really wanted to have you understand that there are a lot of states here that I see that deal with tribes, and you have to include them. They should not be like exactly the rest of the minority population. They need to be treated differently. And that's just something that just to think about. That's all. But I'm going to have to move on. Yes, I'm going to go ahead and move on because I know it took too much time already with just my slides. So I'm passing it over to you, Brian. I'm sorry, guys.
No, not at all. This is exactly what I was hoping you would share with everyone. And I wanted to just quickly screen share the document referenced by Dr. Andrews here, which Mr. Gonzalez has. He'll email out to, I believe, everyone on the call. This is a document on consideration when dealing with Native Americans and RFPs. So if you're looking to distribute settlement funding through RFPs, and you want to make sure that there is some type of representation or inclusion of Native American tribes within your local jurisdiction, here's some really good points that in looking at the distinct political entities that was referenced earlier, how Indian preference and tribal consultation and coordination should be incorporated into that compliance with tribal law and customs, and especially around sovereign immunity, that's really difficult for a lot of us to understand. So making sure that you have representation from a local tribe and consultation and really coordination is really important. The cultural preservation, the training and employment, and some of the other flow down clauses are included here as well. The contact for information for Dr. Bell or Dr. Andrews, sorry, I keep using your middle name there. Sorry, Dr. Andrews, is all listed here. And we would encourage you to reach out if you're looking for more guidance on how to do that. I'm going to jump back over to the PowerPoint though at this point. And There we go. Okay, cool. Is that coming through on the right slide? I believe it is. You have to excuse me again for all the technical difficulties I'm having here. Getting back to ROSAC in the process, we kind of had like 5 main steps that we went through here. We had the introduction and the background, identifying the spending priorities for each jurisdiction. We examined each spending priority. We chose strategies that the jurisdictions would implement, and then recommending using funds to support those selected strategies. So that was over the 15 minutes that I highlighted earlier. These are the 4 main priorities that ROSAC identified. These are all pulled directly from the One Arizona Agreement, which is an extension of the federal award for settlement funds. And then with each one of these spending priorities, as we identified strategies to do that, we actually rated these with a matrix that we developed here. It's a scoring matrix that we went through a collaborative process with ROSAC to identify, and it's based loosely on the Johns Hopkins mechanism for scoring criteria for opioid settlement funding, to really look at the public health impact, equity, accessibility, jurisdictional need, evidence-based practice, community-driven, and sustainability, as it would align with each one of these. And we had a really good conversation about evidence-based practice specifically. This was another place where Dr. Andrews brought a lot of gravitas to the table in explaining that sometimes tradition and culture, even though they can be used as medicine and are totally appropriate within those communities, don't always have evidence-based practice weight behind them. So how do we make sure that there's an elevation behind those proposals where those actions are suggested in a proposal, so that those would be awarded a higher point level, and that is incorporated in our RFP matrices for grading. We did have to make some changes to our additional recommendations based on Board of Supervisors and Mayor and Council feedback. So this is ultimately what we emerged with for a $8 million total supplemental request for the first initial distribution of funding. We allocated 1.25 million to youth prevention, 1.25 to peer navigation support, 2 million to transitional wraparound support. And I want to pause for just a minute and talk about that. So I mentioned earlier that we had feedback from people with lived experience, people who use drugs, who are in early recovery, community advisory board. This was their priority area that they said, we need more resources related to transitional wraparound support. So ROSAC took that into very serious consideration and funded this at one of the highest levels for this round of funding. We looked at law enforcement co-response, mobile medication for opiate use disorder services, or medication-assisted treatment, a safer implementation plan development, which is really like a sobering center, and then again, continued PCHD staffing for multiple staff to support contracting work, evaluation of programming, things of that nature. I'm just going to do a quick scan through some of the selected areas. This is some detail on youth prevention with rationale and example activities. All of this is based off of the detailed study guides that we developed for OSAC, which were 5 to 10-page documents for each one of these categorical areas, which provided evidence bases for why these activities are important, local community needs assessments to support how these were asked for by community agencies locally. MAT is it should actually be MOUD. So we changed the phrasing on this particular presentation, and the continued staffing, and then right now we're in the process of finalizing the RFP, and I want to briefly show one thing that we kind of stole this from Maricopa County, the logic model that they used for their RFP. Okay, are you all seeing this Excel document? Okay, great. So I'm going to briefly scan this. We made sure to include outcomes that were aligned with our overdose data to action local grant for each one of the strategy areas. So we've got short-term, intermediate, and long-term outcomes that map across those areas for each one of these strategy areas. So when organizations propose for RFP funding, they'll need to select 2 of these that they can apply for, and they'll have to include a short-term, intermediate, and long-term outcome for the strategy area that they're focusing on. So peer navigation is where we intentionally aligned OD2A local outcomes. If we get down to mobile MOUD services, like one of the outcomes that they would have to state is that they're looking to increase access to MOUD in underserved areas, improve treatment retention within 30 to 90 day scales, and then reduce opioid related fatalities within the zip codes that they're focusing on distributing MOUD for. And then we took outputs and measures with sample metrics for each one of these. And this is something that we're doing to assist in evaluation for smaller nonprofits that may be applying for this funding. So by having all of these outlined in advance and putting these on a survey 1, 2, 3, this is going to make it really easy for a monthly report to be sent back to the health department based on the RFP that's selected, so that we can continue to show that the funding that we're actually implementing is going towards reducing those fatal outcomes and improving service connection for communities related to these areas. So the next couple steps, and then I'll briefly pull up the Opioid Settlement Advisory Council playbook and have my colleague Linda Cifuentes talk about that. One of the big things that I want to highlight with this is that as stated in the previous presentation, we're actually shifting our focus towards policy. So based on that feedback that we got from the session that we conducted just in May, our behavioral health needs assessment, our opioid fatality review, and several other documents, we're identifying some key policies that branch across sectors, both small p and big P, for organizational level policy, where we can share verbiage across systems, so that a law enforcement policy is going to have the same type of verbiage as a behavioral health organization or as a employment organization as it relates to opioid and substance use dependency. And even look for ways that we can start to recommend strategies for state and local policy at the Pima County and the city of Tucson level. So that's kind of the next steps for ROSAC. I am going to pause here really quick, and my colleague Linda Cifuentes, who's one of our CDC Foundation members, is going to talk briefly about this document that she's primarily been developing, which is our playbook for our opioid settlement advisory committee. And then Linda, just tell me how you want me to scroll through this.
Okay, sounds good. So yeah, so just quickly, because I know we're running out of time, but Brian came up with the idea of like developing this playbook so that we can outline how Pima County developed this group, and that way it could help other jurisdictions do similar work. So some of the things that we cover here is kind of an overview, an introduction to the context of Pima County, why and how we developed the ROSAC, and also how the members were selected, how the agendas were developed, what types of activities we did for the group to identify priorities and solutions for each of their jurisdictions, and also how the role and the structure of the ROSAC was developed over time. And then also a big chunk of it is about incorporating community feedback. So integrating the voices of people with living and lived experience. So this is including a community action board for people who use drugs, people with living experience, where they give recommendations. And some of those members of the CAB, they went in front of the ROSAC members and presented on their own experience, and also the recommendations that the group came up with for how these funds should be used. Also, overdose fatality review, how that information is integrated into decision-making, and then the behavioral health needs assessment. And then there's an appendix with a lot of the different resources, the study guides, for example, that Brian mentioned, and all of the documents that were developed to guide the group through all of the information they needed to know to make the decisions on how the funds would be spent. But yeah.
Thanks, Linda. So we'll turn it over to Mr. Gonzalez here, and that concludes the Pima County portion, which was fast and furious, but do what we can.
Thank you so much, Dr. Andrews, Brian, and Linda, for that quick and dirty summary, although very comprehensive, I will say. So I'm sure our audience would agree on that front, that this was a really helpful conversation to have with you all. If folks have questions for the Pima County team or ChangeLab Solutions team, please feel free to drop them in the chat. We are running low on time here, but we do have time for perhaps 1 or 2 questions if folks have them. And we'll also be sure to provide contact information in case anything comes up afterwards.
Maritza, good to see you here. Sorry, I saw that comment. I got to do a holler out. Maritza's awesome.
I was about to say, y'all are getting some kudos in the chat. Perhaps while folks come up with some questions for you all, again, if you have any, something that is coming to my mind, and perhaps this is a good way of summarizing the playbook, excuse me. Pima County team, do you all have any recommendations for local jurisdictions that are thinking about developing something similar to the ROSAC, or perhaps they already have a committee that is up and running, but are trying to figure out how to best leverage it as a decision-making and or advisory body? Any tips that you all have? Very curious to hear what you have to share.
Yeah, I'll start and then just kind of pass the ball a little bit. I think one of the important things is and this is an area where I think we could probably do a little bit better, but is representation. I think we really have tried to ensure that people with lived experience are included in how the decisions are made, and how they're informing the regional committee. And I think there's always room to improve on that. The other area that I think that for us personally has been really important is what Dr. Andrews has brought to the table with making sure that there's a support system and ensuring that Indigenous and tribal values and voices are expressed and heard in real tangible ways. So including language in our RFP that's connected to that document, the PDF document that Dr. Andrews developed and sent out, I think is a really important factor as well, especially because in our community, that's the community that's most disproportionately affected by overdose fatalities. Data, and really this gets back to data to action, right, is ensuring that the data that we're capturing that shows where either disparities are occurring or where impact is most felt in communities, ensuring that there's mechanisms built into the actual release of funding that can ensure that the connection of care to those communities is really important. And the broadness in the spectrum of medical, behavioral health, people with lived experience, folks that work in poverty, folks that have good relationships with their tribes and connect to those communities, and include law enforcement too. I think that's a strength of our committee.
Thanks so much, Brian. Dr. Andrews, I'm curious if you have any recommendations as someone that's sitting on the committee.
I think that I agree. What I like is the fact that Brian is open to hearing us. I feel like I'm being heard. I feel like, what I bring to the table, they make a lot, they include it. And it's not just me, it's everybody who's on there who represents some group of people. And I like you said, I think, gosh, I wish we could have more people on there, but right now we're just trying to build a foundation right now. Also, just keep in mind that I really want to emphasize the fact that many of these communities, of course, we know there's some issues going on here. I mean, we even talked about the immigrants that were dealing with this issue here in the United States and how this adversely affects them. And how do we find solutions to that? Just trying to, and also let's be honest, NIH, the LGBTQ community, they disfunded that where I'm at up there. I mean, come on, really? And in the United States, this is ridiculous. But anyways, point is that bring those people to the table. They have a voice. And unfortunately, their voice at the higher levels being, bagel, right? It's being, it's not being heard. So they are huge. All these people that are important to us. And, if they don't have, it's going to affect us. If we're not going to them and looking at, looking at their needs or having their voices heard. And also mind you that a lot of their voices aren't heard because there's no data to support it. Not just natives. Okay. We're talking about the people who are not US citizens, whatever you want to call them, but they contribute here to the United States. They also deal with issues, but they can't because they're afraid of what this is all happening, of having their families dismantled or what have you. we have to remember they're out there. I'm just throwing it out there. I know we do it even on our committee, but those voices don't have that data. So make sure your RFP realizes that there's people that don't have particular data, not because, you know, I guess don't make that a requirement all the time. Just make sure that these voices are heard as well, because right now at the federal level, they're being cut. It's cut and it's ridiculous. Anyways, that's my soapbox, and I'm going to get off of it right now. But yeah, everything that Brian said, I really appreciate. So thank you.
And this actually bridges to a really good point, right? Is because committee members can say things that I can't, you know. So find, I would say to y'all in the community that want to do this, find the passionate people like Dr. Andrews from your community that can advocate for those voices and bring those voices to the table in ways that you can't because you have that government employee label. It's a massive gift, and it really does go leaps and bounds to serving the communities that need the help.
Thank you both so much. I think that's a really powerful way to end us off here, and a good call to action for those folks in the audience that are thinking about how to bridge the voices of those with lived or living experience with the really powerful work that government entities at the local level are doing. So thanks again to you all, and to Christine and Jessica at ChangeLab for sharing your expertise today. As we start to round out, we'll go ahead and share with you all a link to our resource hub. With Big Cities Health Coalition, Prevention Institute has developed an online and fairly comprehensive resource hub where you'll find additional guidance on opioid settlement fund planning, implementation, and evaluation. So we very much encourage you to access this, explore it at your own pace. You'll find on this page recordings of all of our webinars, both for this year's series and the previous year's series, all relevant to opioid settlement fund planning. So please go ahead and take a look at that after this webinar. It's something that we continuously update and try to maintain fresh. So very much encourage you to take a look. With that, we will bid adieu, and I'll go ahead and drop on this slide contact information for all the folks that we had share their time and expertise with us today, as well as my contact, Michaela Johnson's from Big Cities Health Coalition. And if you are able, we would appreciate your feedback through a short poll that my colleague will launch shortly. Responses are greatly appreciated in shaping our understanding of the value of this webinar, and to make sure that we can fine-tune future content and future conversations for you all as well. So we'll stick around to give you that time to fill out the poll. Again, if you are able, we very much appreciate it. Otherwise, we very much value your time and spending your hour and a half with us today. We hope you learned as much as we did. Thank you all so much.
Thank you, guys.
Thank you.